No response. That's either good news or bad news. Can we pop a message in the chat, please, Max, just to ask if she may well be otherwise engaged temporarily and joining us momentarily. Okay, good morning, everybody, and welcome to our first official meeting of the Somerset Board. And it's a delight to welcome you all here to Dean House in Taunton. For those of you who don't know me, I'm Councillor Bill Revens. I'm the leader of Somerset Council, and in that capacity, I chair the Somerset Board, and I'm joined by my Vice Chairs Paul van der Heide, and very shortly, I understand, by Councillor Adam Dance, who is on the way, I think is what we'll call it euphemistically. I wonder whether, as it's our first meeting of the board, we might do this. If Professor Grant, I wonder whether you would like to kick off, and then we'll go around from you.
I will. So Trudy Grant, I'm Exec Director of Public and Population Health for Somerset Council and Somerset ICB.
Good morning, I'm Bernie Marden, I'm the Chief Medical Officer at NHS Somerset.
Good morning, David McClay, Exec Director of Strategy, Digital and Integration, NHS Somerset.
Good morning, I'm Lou Woolway, I'm Service Director for Public Health and the officer that supports the board.
Good morning, I'm Ewan Jones, I'm representing the Somerset Association of Local Councils. NHS Foundation Trust.
Good morning, I'm Superintendent Lisa Simpson, so I'm the new Area Commander for Somerset and North Somerset.
Good morning, I'm Hilary Robinson from the Registered Care Providers Association for Somerset.
Hi there, Chairman of Somerset Integrated Care Board.
And Bill Revens, leader of Somerset Council.
Alan Jones, Exec Director, Somerset Council. Jamie Jackson, Democratic Services, Somerset Council.
Hi, I'm Lucy Trimnow. I'm Opposition Lead for Public Health, Equality and Diversity.
Mel Locke, Executive Director for Adult Services.
Okay, and Heather Shearer, I'm Associate Lead for Children's Services at Somerset.
Hello, morning, Jonathan Hickman, Chief Executive, NHS Somerset.
Good morning, I'm Robert Weaver, I'm a GP representing primary care.
Morning, I'm Steve Taylor, I'm the Chief Executive of the Cabot Learning Federation.
Hi, John Revel, Principal, CEO, Strode College.
Good morning, I'm Catherine Nolan, Chief Executive Spark Somerset, representing the voluntary sector.
Hi, I'm Angela Kerr. I'm also representing the voluntary sector and CEO at Citizens Advice Somerset.
Liz Leishan, lead member for Resources and Performance at Somerset Council. Really glad I'm sitting next to these two because I can introduce myself at last. Thank you.
And James Rimmer, Chief Executive, St Margaret's Hospice Care.
Okay, thank you so much. I always feel like Cilla Black when I say who are you and where do you come from, where that'll end up. So the agenda pack with the papers is available via ModGov if you have access to such a thing, directly from the council website, from the link that is sent out to members. And in line with recommended meeting procedures, I'm requesting that all members and officers turn off all microphones and videos, but please remember to turn on microphones and videos when you speak, and this helps with the background noise, call quality, and with anything disrupting the meeting. When I invite someone to speak, could you clearly state who you are for the benefit of anyone who is listening to the meeting so they can identify who is speaking? And can I remind those people online to only use the chat function solely for committee business? Otherwise, it is distracting if there are other questions or conversations happening. So a warm welcome to anybody who's online or in the room who's a member of the public or any media. I'm not sure there are any media here today, but I do hope we get some more public interest in the future. Agendas are now viewed electronically, so if you are referring to something specifically in a paper, it would be great if you could refer to the page numbers so it's quicker for people to find that place on the published information. Okay, so I'll proceed with the agenda, and the first item is apologies for an absence. And Matt, can we have apologies that have been submitted for absence, please?
Yes, apologies from Sarah James, Michael Lennox, Judith Goodchild, John Worsley, and Peter Lewis.
Thank you very much. Are there any other apologies that have been brought forward from members? Heather Shearer.
Forgive me, yes, I think also Councillor Dean Ruddle is still on leave.
Indeed.
Chair, I believe Councillor Dance is running late as well. He's had a car issue.
Okay, I will look forward to seeing him shortly. And any declarations of interest? Those of us who are councillors will have our interests as members of other councils available on the website. Are there any other declarations of interest? No. Okay, and we move on to public question time. I'm advised there are no members of the public with questions. No, and not seeing any contrary indication, which moves us on to item 4 on our agenda, which is the introduction to the board and how it will work, which is item 4. And I'd like to invite Professor Trudy Grant to introduce the board and our way of working. Trudy.
Thank you. I'm going to do very quickly, and then I'm going to pass over to Lou, who's going to take the bulk of the agenda item. But as most of you know, and as Bill has already said, this is our first formal board like this. We've had a number of informal workshops for those who aren't member of the board, just to start to get to know each other better, but also to start to have some hopefully productive conversations about what some of the main issues are that Somerset faces now, but also looking forward to see what the issues are that Somerset faces in the future. We particularly wanted to look forward quite a good period of time, because actually most of us are very focused on the now, and not enough of us are focused potentially on a bit further forward. So we looked at work which was pushing forward for about 30 years' time. What does Somerset look like in 30 years' time if we carry on with the same trajectories that we've got now? So we'll talk a little bit more later on in the agenda about some of those findings, but essentially we're looking for this to be a new, fresh beginning. It's got new membership on the board, which we're really delighted about, far wider membership than we've had previously on the Health and Wellbeing Board and Integrated Care Partnership. So as senior leaders within the county, I think it's really important that actually we all know each other well, that we're all looking at the same information about our county, and that we're all striving towards the same things in our county. And that's what this board is all about, really. It's all about making sure that we all understand the position that we're in, and we set the strategic direction for our county going forward and work together to achieve it over the longer term. So I'll hand over to Lou, who's going to do a little bit more about the intricate processes that we're going to use.
Thank you. If you can go on. As Trudy says, this is a brand new opportunity. So I know I've got a mixture of people who have been part of the committee and common approach before with the Health and Wellbeing Board and the ICP, and people where this is absolutely brand new. So we've drawn a line and we're all going forward at the same pace. So if you're brand new to the board, it's great because it's starting from fresh. So just as a reminder, you are a board of 3 actual things. So you are board members of the Health and Wellbeing Board, because we have to legally have one of those. We also legally have to have an integrated care partnership. So you are also a board member of the Integrated Care Partnership. And the way we've done it in Somerset is to bring those 2 together to be represented by the Somerset board, because we are a single footprint. We're a single local authority area. We're a single integrated care board area. And so that was the most simple way to do it, so that we didn't have 2 lots of meetings happening at the same time with the same people on them. So we've done an awful lot of work to work through the governance and the processes attached to that. So at times, there are statutory functions for both elements of that work. You will be told that you are acting on behalf of the Health and Wellbeing Board, or you're acting on behalf of the Integrated Care Partnership, and that will be minuted by our colleagues for governance back to the council and back to NHS England. Does that make sense? So it's a triple hat, really, in essence. Most of the work we need to do is about defining the needs and being very clear as a Somerset board, what are the strategic needs of the county? And it's about, as Trudy said, determining that longer term approach. We need to take a really long term approach to tackling those. What's our vision? And working towards agreed priorities. And then directing how that work happens in the county. Those of you before will have heard me talk about sticky bits. The idea being, if there are sticky bits in the county that are stopping progress or need to be thought about, this board is the very, very, very senior people in the county. If we can't unstick the sticky bits here, there isn't anywhere else we can unstick those sticky bits that impact on the health and well-being of our local population. So whereas in the past we would receive reports from different parts of the system, so safeguarding or some set partnership around being safe. The idea being that you are board members, you understand the strategic direction, you understand the needs and you understand the priorities, and you feed them out into your organisations and then any associated boards attached to those organisations. So we won't be receiving lots of written board papers back to the board where we acknowledge work that's already done. The idea being that this influences the work that needs to happen. Does that make sense? So it's a very different stance to before. Okay. So there are statutory duties, as I said. There are 3 statutory duties. Well, could you go forward, please? Sorry. There are 3 statutory duties of the Health and Wellbeing Board. That is to write the joint health and wellbeing strategy. For Somerset, that is the Improving Lives strategy, and we did it as a 10-year strategy. Trudy will pick up a little bit more on that in another agenda item. The board also needs to write the Joint Strategic Needs Assessment, the JSNA. That is defining the needs of the population as we go forward, and we should all be referring to that with our commissioning and our service delivery as we go forward. And the board, the Health and Wellbeing Board, also needs to do the pharmaceutical needs assessment. The Integrated Care Partnership similarly has a statutory strategy, that's not easy to say, the Integrated Health and Care Strategy. They are linked, the Improving Lives and the Integrated Health and Care Strategy are linked, but the role of the ICP is to define and deliver that strategy. So there will be a standing agenda item on the board to make sure that we're fulfilling that agenda item as well. And the proposal is that those are the items that come to this board when we meet in public. So we meet in public 3 times a year. And again, the idea being that the board, they come at a time when the board can influence decisions around them, not coming when decisions have already been made and it's for information where possible. Okay, can we go on again? We also have the Health and Wellbeing Board needs to have oversight of this SEND agenda, special education needs and disability. And it also has to sign off the Better Care Fund, the joint fund with NHS and social care. And my proposal here is that actually we delegate that to very senior officers who meet in other boards, who are the experts, if you like, on that particular topic. So for example, the Children and Families Board, which is part of the Integrated Care Board, will have oversight of SEND and children and young people and things like that. We will delegate on behalf of the Somerset Board, is the proposal, that they act on behalf of the board within that work, and we work out how we report back to this board, and particularly if there's any escalations that need to come back, particularly around those sticky bits or other things that board members should know around that agenda. Claire Winter, who is our Director of Children's Services, who isn't here at the moment, is actually the chair of that board. So it fits that the board member sits here and actually is chair of that board as well. Similarly, David, sat to my left, with the Better Care Funds, there is now a joint commissioning steering group with director level colleagues on, where the Better Care Fund is going to be discussed and implemented. And again, the idea is we would delegate on behalf of the Somerset board to that group, and David is the link between the board and that steering group. So again, we wouldn't need to have complete oversight of those at the board. We would use it as a way either to direct the conversation down into those groups or to have conversations coming back up to the board. Happy to take questions at any time, or we can look at them at the end. If you could go on again. Now, there are lots of guidance that say what the Health and Wellbeing Board should do in other acts that has never been tallied to the guidance that's come down from government for Health and Wellbeing Boards. So I've tried to unpick this as well. So as the chair of the board, many things should go past the chair of the Health and Wellbeing Board. And again, in order to do that, so one of those being the Somerset Safeguarding Adults report. Previously, we used to have them come to us twice, once to tell us their work programme and one to report on the work to date. Again, I've been working with colleagues who run that programme in the council to say, can we start to do written briefings on those? Or actually, if there was a problem, could we start to use the private workshops to unpick some of those areas around adult and children's safeguarding, for example, rather than boards coming to here for information. Similarly, with the Children and Young People's Plan, again, that used to come to the Health and Wellbeing Board for information. That is sitting in that Children and Families Board. And again, as part of that delegation to the Children and Families Board, we would pick up any issues around the Children and Young People's Plan going forwards as well. There are also requirements of integrated care boards and NHS trusts, and they must involve the Health and Wellbeing Board in the preparation of their forward plans and must demonstrate how they've taken into account both the Joint Strategic Needs Assessment and the Improving Life Strategy. And again, we're quite joined up around those plans anyway, but again, it would be around written briefings, pulling into workshops if we needed to, if there was a particular issue. The board papers would come with an officer. So if you had any questions about anything, you could send questions in or talk to a named officer who could give you more information. And then for an audit trail to meet the requirements of the other side of the equation, we would minute that we have had those reports distributed, there were questions or there were no questions, and we could go forward in that way.
Forgive me, and perhaps I should know the answer to this question, but it's lovely that the Safeguarding Adults Board output is something that's good enough, if you like, for the Health and Wellbeing Board. I just wonder whether the Children's Partnership, Safeguarding Partnership, was ever expected to come to the Health and Wellbeing Board, or was that dealt with in another way?
That's dealt with the partnership, Children's Safeguarding Partnership Trust. We used to have it come for information, but I think if we badged safeguarding together, adults and children all age, we could keep an eye on that safeguarding agenda going forward. And again, if we started to see some trends or some areas of concern, we could either bring it to the board for a public meeting, or we could pick it up in more detail at a private workshop, if that makes sense. Okay. Oh, yes.
So just a question around the link with the NHS planning process and the joint forward plan. That work tends to happen in the first quarter of the year. So there's something that we just might need to think about around timing. So if the meetings are 3 times a year, quite a lot of that work will now be taking place between sort of January, March, April time. So we might just need to think about some degree of delegation to enable that to happen. I mean, clearly the guiding light for all of that will be the integrated care strategy. So we just might need to think about the practicalities of it, given the timeline for planning.
Definitely. There's still a lot to be thought through. This is this is the approach that I'm seeking approval for at this stage. Okay. So the workshops, we did say that we would set up a number of workshops. They're not defined in number just yet. I think we usually go for about 3 a year, as well as the 3 public meetings. Healthwatch couldn't be with us today, but being able to influence their work programme will be a really good way to start to get that public engagement in the work and the priority areas of the board, for example. So I've been talking to Judith about that, and Gillian as the manager of Health Watch. We've got an item in a bit on the priority areas that we developed through the workshops. So we might want to pick up some of those much more in more detail and understand where we are. And then anything that arises from any strategic conversation we have here that you might want as board members to bring forward to the next meeting, we can do. And the idea being with those work programs and workshops, we can start to bring in the wider stakeholders and bring in members of the public. The new guidance, both for the integrated care partnerships and the Health and Wellbeing Board, talks about having much more public involvement. I'm not sure members of the public always want to come and sit and listen to these meetings, but actually, for example, through the housing work, which you'll hear about shortly, doing health needs assessment, we're doing focus groups with different members of the public to start to understand need. So we can start to take forward the work that starts to bring in the public around those priority areas. The other important thing is that we will also have defined outcomes and metrics for our priority work, and we will have a scorecard, because actually I think we need to demonstrate what the board does and how successful it's been over time with those outcomes and metrics. Again, Trudy will talk a little bit about those, and we may need to refresh them, but the idea being that this board would have a performance scorecard that we can talk about those work programs and how they're going forwards. That's the proposal. Sorry, James.
So thanks, Lou. So for me, just the question is how and where can we have that flexibility kind of to make sure we're considering things coming from the outside. I'm particularly minded of just recently Chris Whitty has put forward his latest annual report, CMO annual report, looking about health in an ageing society, which I think has got massive implications for Somerset, what kind of really speaks to Somerset. It talks about cities being forever young, and then somewhat challengingly, I think, talks about the periphery being coast, which she's talked about before, but also rural and semi-rural areas, but ageing being such a challenge and how we do that. Now, I think it fits well with our strategy, helping people live well and, dare I say it, die well. But, I think we would need to think about how and where we bring it in as part of it. So that's an example of something that's coming in real time. So it doesn't stop it, but making sure that we have the opportunity to just consider it. Do we need to just check and challenge ourselves, and how do we bring things like that in as part of it? And again, his challenge there, and I think you're right about this forum, is yes, more people are going to get older, and therefore the number dying are going to increase, but actually how we bring in education, so we're training people locally as well, is a really good kind of contrast.
Thank you, James.
Perfect. And we have two of our education leaders here for that very reason. And if you think about the egg, Trudy and I often talk about the egg, the white of the egg and the yolk of the egg. We've aimed to have very senior leaders who can represent all of the egg, so that we're beginning to have those conversations. Yeah, I listened to his very good, he did a lecture on healthy aging and trying to move the curve to the right at the point at which people get their first disability or long-term condition. So I think it is taking that whole age approach and the preventative approach. Keep that in mind for my next agenda item, because it's about how we approach the work that we do as a board as well. And I think as well, we really need to get the accountability piece in here. So Trudy mentioned it's really important that this board has good relationships amongst you all as system leaders, because we do need that check and challenge. The downside of being a single footprint for an ICP and a Health and Wellbeing Board is you're not getting that critical friend approach from other local authorities or other ICBs. So we do need to be mindful you've got 3 hats on and we might need to build in a little bit more of that accountability piece and the check and challenge as we go forward.
Lou, I almost like a bingo card as who was going to mention Trudy's egg first. And I'm not sure that everybody in the room will know what Trudy's egg looks like. Indeed, if we could find that, because I have a funny feeling it's going to be mentioned on a regular occasion. And it is such a powerful diagram of what this board is all around. And we just need to make sure that everybody's familiar with that optic. Looking around for any more questions or points, and Trudy's come to tell me off about something.
No, I'm not telling you to Phil. We'd never do that. I just wanted to, I think it's really important that we clear the agendas that we got very clogged up before with all of the reports. And so I think Lou's proposal is right, that we delegate the responsibility to other specialist boards, more specialist boards that we've got going in our county. That I think we need to trust with some of those more formal things that normally traditionally would have come to this kind of board. But I think it's really important that we draw a line in the sand of what we've had before and go forward in a very, very different way. As I said earlier, this is a board of very senior leadership people across our county from all different sectors. And that's absolutely right. And to my knowledge, unless any of you are going to tell me otherwise, I don't know of any other board like this that we've got in our county. There is no other board where very, very senior leaders across this wide variety of sectors comes together, which makes it for me a really, really important board. And I hope it will in time for all of you folks as well. But it also means that, as said earlier, we do need to get to know each other. We do need to make sure that we have that kind of team approach to addressing some of the long-term issues in Somerset. But being able to clear the agenda of some of the things that we've had previously coming to the board means that we can have some proper debates about what the big issues, the big ticket items are for Somerset in the longer term. And there is no other place, to my knowledge, that we have those kinds of conversations right across this number of sectors.
And as if by magic, said egg appears on the screen. Thank you to David. So for those of you who haven't seen it, this is the health and wellbeing system, if you like, for the county. The yolk of the egg being those health and care services, including public health services that are provided to hospitals, primary care, community, social care, etc. The white of the egg are those wider determinants of health that really impact on the health and well-being, what it's like to live and work in Somerset. So housing, education, work opportunities, poverty, all of those wider determinants that we also need to think about. And we need some scrambled egg. We keep talking about this, but we do need to scramble the egg between the yolk and the white. So we need to influence the spend of our NHS and social care around that wider determinants, and we also need the influence the other way into the wider determinants of wider determinants of health. I've got eggs on the brain now, but that's where we're heading. So that's why we've chosen this group. This group is much bigger board than the previous arrangements, but it is deliberately so to try and cover all of those elements of the egg. Hopefully that makes sense.
Thank you, Lou. Just by the way, it's always a Cadbury's cream egg in my thoughts, which is probably
the boiled egg in
good.
mine, not fried.
Okay. Are there any more questions for Lou? Oh, Alan.
Chair, if I may, just to place it in context as well in terms of the wider issues that Somerset is experiencing at the moment in relation particularly to our finances across the system. And we're looking at how other authorities are considering these matters and how external bodies are considering those impacts. It's quite critical that we have a board like this to be able to consider those matters. You'll note from a number of different reports, so you can imagine that I particularly spend a lot of time reading those types of reports at the moment. And it's quite clear that an answer to the bigger question, that longer term strategy, tends to be the way in which those reports finish. So for those authorities or systems that are under stress, anybody that comes in and reviews them externally tends to take a view that, yes, they have a grip, yes, they are solving it. However, there is no long-term plan. This board gives you the opportunity as members to provide that long-term strategic plan and answers the questions that auditors and similar will often level at you as a system. So this board gives you the opportunity to consider those bigger issues and that longer-term strategy. So it does have a hook into some of those requirements that you're all going to be tested on as a system. Thank you, Chair.
Thanks, Alan. Okay, not seeing anyone else wanting to speak on this item. I think it's really important to highlight that this is a fresh beginning. It does give us new opportunities, but that co-locality that we have of having the ICB and the Health and Wellbeing Board having the same geography does help us to have this common purpose. And yes, solving the sticky bits is important, and doing the statutory duties is important, but it is that long-term vision for me that there's real opportunity here lies, that we are aware of the demographic issues, we're aware of the statistics that lie behind those, and we need to find solutions to make Somerset a healthy and sustainable place to live over the long term, and that bringing together strategic leadership in Somerset for me is what is so inspiring about having this forum in which we can do that. So thank you so much, Lou, for that presentation and for colleagues' questions. Which moves us on to item 5, which is the Improving Lives Strategy and Integrated Health and Care Strategy. And I'd like to invite Jonathan Hickman to share an update.
Will I do mine first?
Oh, okay.
No, it's okay. It probably wasn't on your sheet. Max, could you put the slides up, please? So just to be clear, as Lou said earlier, we've got 2 strategies, and we just needed to make sure that everyone was really clear about what they were and how they fit together. So the Improving Life Strategy is our version in Somerset of our health and wellbeing strategy. When we first started having a health and wellbeing strategy in 2013, it was a 3-year strategy, and it was called the Somerset Health and Wellbeing Strategy. The issue we had was that quite a lot of people in their normal everyday lives and their day jobs don't necessarily see that they've got a role to play in improving health and wellbeing. And so for this strategy, we changed it to be an Improving Life Strategy, because people working in all different sectors, in all different disciplines, were able to recognise that they've got a role in improving lives of Somerset residents. And that was easier for them to connect to than improving health and wellbeing. So it is our health and wellbeing strategy, but it very clearly is about improving lives and encompasses all of life in Somerset, really. It is the whole of the egg. So the Improving Life Strategy covers the health and care services that we've got in the county, as well as all of those protective factors, the wider determinants of health that Lou mentioned about, that's in the white of the boiled egg. If you go on to the next slide, please. It has 4 main priorities. I should say, actually, that this was developed in 2019 after about a year of consultation. We did lots and lots of work out with the public on what this should look like. So it was very well consulted on. It came out with 4 priorities, which are these. And it was decided at that time that it should be a 10-year strategy, because actually quite a lot of these things you're not going to shift within 3 years. So at that point, actually getting it to be a 10-year strategy was quite revolutionary. And we were really chuffed with 10 years. I now wish we'd gone for 30, but we were pleased with 10 years at the time. We then, obviously, this was 2019, at the end of 2019, as we all know and love, we then came across COVID. And to be honest, this kind of work sort of took a back seat for quite a long time. And so we're now in a position, I think, that we need to revisit this again. I think we need to do a bit of a light touch refresh, if the board are in agreement with that. And in particular, look again at the metrics that might need to go behind some of this, because actually the chances are that's changed after COVID. I think that's probably all I wanted to say, but I think the light touch refresh, I think we probably do need to agree as a board if people are happy. On first glance, these 4 priorities still feel as though they're right for Somerset. And certainly from the conversations we had in the workshops, they match quite well with some of those conversations and some of the concerns that we were seeing going forward. But if the board aren't in agreement with that, and actually we need to do a whole new let's start again sort of approach, then shout now, and we'll put forward a proposal along those kinds of lines. But the proposal here today is that we look at a light touch refresh for the Improving Life strategy, and we look in detail at what the metrics are behind that strategy. We absolutely need to look at the metrics and how they line up with the integrated health and care strategy. On that note, I'll pass over to Jonathan.
I was just going to ask if anyone wants to shout now, because you had invited
absolutely
the shouting, and well, I hope that nobody actually shouts, but I do think it's important that we just take that opportunity to take that feedback. And I've got Colin who'd like to speak.
Thank you, Bill, and thank you for that. Where does communication and education fit in that? What's striking me increasingly is all of us providers around here are finding better and better ways of trying to help people in Somerset. We're not perfect, but we're actually coming up, all of us, with more inventive ways of doing things. We can't do everything, and I worry that there's a message out there that people may think we can solve everything, but there are certain health conditions that if you get them, it's the best will in the world, the prognosis is very bad. So are we doing within either the Improving Lives enough on that, or within one of our other strategies, to communicate with individuals out there on the need to look after themselves? And does that figure in there?
So yes, I mean, right the way communication and engagement with the population fits right the way through the strategy. So it's almost an enabler to the whole thing, to be honest. And the same, I'm sure, will be true when Jonathan says about the integrated health and care strategy. When you first started talking, I thought you were talking about education, but it's more about communication, isn't it? You're suggesting.
Communication.
Yeah.
Education.
Yeah. So it is very much about it. The vision behind the strategy is very much about supporting individuals to improve their own health and well-being, but also making sure that we, as a whole county, develop an environment which is conducive to people living a more healthy lifestyle, and being able to adopt the healthier choices and make the healthier choices an easier choice. So there's kind of two strands to it, really. There is an element about us supporting individuals and educating individuals and helping them to make the easy choices. But there's also an element of we need to make sure that where we possibly can, that we've got an environment to make that easy for people to do. And that does run all the way through the strategy.
Thank you, Steve.
Yeah, thanks, Julie. You mentioned the possibility of having I suppose, a light touch revision. And I suppose that maybe one of the questions might be, is there anything related to the pandemic, if we were to run that as a filter through the strategic priorities, that so fundamentally change the starting point that would potentially take 10 years for us to be in a place where we feel that's resolved or those challenges have resolved themselves? There may be evidence, I suppose, to say that aspects of the pandemic have had a deeper impact in Somerset than perhaps elsewhere. And I don't know if there's already been a sense of consideration of, do we really know what those short, medium, longer term challenges might be, and if it's worth feeding that, if there's some kind of audit position, start position, almost like a reconsideration of the start position up until 2028, because there may be some fundamental shifts in our baseline.
So yeah, I think it's a really critical question, actually. So part of what we've started to do is to look at the data coming through now, but some of the pandemic effects aren't coming through the data yet. So some of them are such longer term pandemic effects that they probably won't be seen for several years. So we almost, if we were going to do a light touch refresh now, We can do it with those that we know that there's been an impact on, but actually we almost need to do it in another 3 years probably as well, when we start to see even more of that intelligence come through. The one thing we do all know is that we know that the pandemic has really shone a light on the inequalities in our communities. And if there was one thing I would put my hand on my heart and say now, we had absolutely inequalities running through this strategy right from word go. I'd say that's been amplified tenfold from the pandemic, and that if we do anything about a light touch refresh, inequalities needs to be in there even more than it was before, I would say. Does that answer your question?
Thank you. I was reminded of Donald Rumsfeld and the unknown unknowns as you were speaking now, and I think that's absolutely right. The other thing that I would say that we've learned from the pandemic, or we've been again shone a light on, is the importance of community support, and the ability of our communities to be able to step up and support each other, which I think has been historically perhaps untapped. And I think there's been a reversion back to the status quo pre-pandemic, and it would be great to see if that return to be the new normality, where our communities were more supportive of those more vulnerable in our communities. And I've got Heather and then Marjorie.
Sorry, thank you. I just really to amplify some of the points that Trudy was making. I think it's really, and colleagues, I think the baselining is really important, but I think it's that thing about the 4 priorities can mean everything to everybody. That top line is often like that. I think the detail comes in with the planning and those what we're going to be measuring is what success looks like. And I think all of that's where the effort needs to go in. I'd be less bothered about changing the 4 as I would be about putting the effort into unpacking what it would mean, how we know when we've got there.
Thank you. It's just a small point. If there is a light touch review, I don't really understand what a well-balanced community is. And I think we could, it speaks to your point that the detail will come. But I do like those priorities. And in terms of engaging the wider voluntary sector, we would work at that level initially. So it would help if there was just a little bit more clarity around what a well-balanced community is.
Yeah, I can see that. If you weren't involved in the conversations at that point in time, that's quite a tricky one to get your head around. So at that point in time, part of the conversation and what was coming through very strongly was that Somerset has less well-balanced communities, we think, than other areas. So a particular example would be our aging demographics and the fact that we've got some parts of the county that have even already over 50%, well over 50% of the population over the age of 65. So that was part of it, is actually as a county, do we accept the demographic change and work with it? Or actually, do we actively want to do something about changing and starting to try and reverse that demographic change? So that was one example. There's quite a few other examples. I mean, we've now got the resettlement program, which actually wasn't anywhere close to as big as it is now when we first wrote this. Actually, we're starting to get slightly more diverse communities, and actually, wouldn't we want a bit more of that? So that, it's the kind of, is that kind of well balanced. That was the way it was meant at that time. But it may be something as a board that we want to explore a little bit more.
Thank you. Ewan?
So I would add first, I think the pandemic highlighted inequalities at actually a very micro level in the community. So it's like street by street. You'd have some areas of individual towns that, let's face it, are more affluent, and they were very good at supporting each other. The areas where there is greater deprivation, there were greater problems, and it was less easy to get rural pods going. I'd say one of the things that has changed since then is almost our own challenges, the financial problems of the council and the new unitary council. So Alan wouldn't be surprised if I'd observe that local community networks have huge potential. And we've been running one in South East Somerset since May 22 as a pilot phase with a health and wellbeing theme. I'd observed that the ones that weren't running the pilot phases have not yet built capacity. So there needs to be greater support in providing to those, particularly when we're doing that as SELP with the Health and Wellbeing Project, which is about building health and wellbeing capacity. One of the things I'd actually like to get out of today, or a message to get people to start thinking about, is how the local community network should engage better with the local health services. Because I have to observe, we found it easier with the police, who are integrated with the local community networks quite well. And it may be just our local community network. We haven't found the right way yet to work with the statutory health providers.
I think you have won the prize for the first sticky point.
So thank you for that. You've hit the nail on the head for an agenda item in the not too distant future, in about half an hour. So keep that thought, because actually that does come into one of the agenda items a bit later.
Thanks, Trudy. Have I got anybody else who wants to speak on Trudy's bit? So it's now over to Jonathan. Thank you.
So over to me. So I'm going to talk specifically about the integrated health and care strategy. And essentially, just before the slide vanishes, what we're talking about is priority 4 on the slide. So the implementation of health and wellbeing, more people living healthy and independent lives together. And essentially, I guess that's also what's going on in the yolk of the egg. So just keeping that analogy going. So the improving life strategy and the health and care strategy fit together in that sense. So I think that's message number 1. We published the integrated care strategy in June of this year, June 2023, and it was developed through a process of engagement in the period leading up to that, but also I think builds on the work that was going on in Somerset anyway. So it wasn't a kind of, we're going to start again and we're going to create something brand new. We're now in a phase where we are moving into the implementation and prioritization of that strategy. And I think, so for me, there's 2 kind of guiding principles within all of this. One, and I think it sits within the center of the integrated care strategy, is that fact that within Somerset, there's a 17-year gap between life expectancy and healthy life expectancy. So people living on average 17 years in poor health, and in our most deprived populations, you can add another 9 years to that. That's a pretty staggering fact. So we've got that as number 1. And then from an NHS perspective, we also know that 10% of our population, 10% of the people in Somerset, account for 70% of the spend, be that spend and resource generally. So the incentive of the strategy is to do the right thing around providing more local support and more earlier intervention, more prevention to the population generally, but actually specifically to that 10% of the population who are the people who are living with the most complex needs. Now, largely they are the frail elderly, but they're not only the frail elderly. They are people with complexity and living with multiple long-term conditions. So the thought being, actually, if we can left shift, if we can really provide more support in communities, much more locally, what that enables us to do is to unlock resource from within the system, but actually also really critically provide better support for individuals, and over a period of time reduce that 17-year age, that 17-year gap. So it all fits together kind of very nicely. The question is, what do we do about enabling that to happen, and how do we really shift the resource and the focus from where we are today, where we spend half of our money in acute services in hospital, caring for people when they get sick, to shifting the dial so a larger proportion of our resources spent supporting people in communities, earlier intervention and prevention downstream. That's the real challenge for us. So we've kind of set some great things in here, which I think, and I hope the board would endorse. The real challenge now is over the course of a period of time to make that shift. That isn't going to happen, tomorrow. It is a longer term strategy, which is why for me this is really encouraging, because it goes alongside all the things that we know that we should be doing today that are kind of imperatives for the NHS. There's a paper in the pack, and the paper effectively asks a number of things. One is a lot of what's suggested in here is effectively the work of the ICB in terms of the implementation of that. And now we need to make sure that we've got a clear link between that work that's going on every day and back into the Somerset board. We've created a forum called the Collaboration Forum, which is a partnership of senior executives from across the system who've been working on the priorities, and the priorities are set out in the paper. There's a triangle in the paper with 5 areas of priority in there. And those are supporting and enhancing our population health management approach, integrated neighbourhood teams, which I think plays to the comments about actually getting deeper into and working with communities, and that connection not only around creating integrated teams that provide care, but actually that broader support and community resilience that needs to sit around that as well. And I think the question around the LCNs is really critical to that. How do we make sense of the complexity that we've got to enable local people to really start to play a part in this? We've got a challenge around resilience of primary care, because primary care in its broader sense, that's not just GP services, but it's dentistry, optometry, community pharmacy as well, is really critical to us enabling that to happen. So we've set that as a priority, and a set of things around the delivery of care. So some of the issues around urgent emergency care, elective recovery, so reducing the number of people on our elective waiting lists over a period of time, and mental health, the 3 kind of subsets within that. So the next set of work is effectively to put some meat on the bones of those priorities and start to do some work. And I think the one that sits in the middle, the integrated neighbourhood teams, is absolutely critical to the delivery of this. And it aligns quite nicely with, I think, what we're going to come and talk about in a moment about the priorities of this Somerset board. So essentially that neighbourhood and locality working, the health and housing working that we had talked about before. But I think critically also there's something around us having the intelligence, and I mean that in a broader sense. So it's about data, but it's also about Colin's point around how do you have real engagement with the population, so you get that softer intelligence about what it feels like to live in communities in Somerset, and what people are telling us about the way that their services need to develop. So we want to create over the course of the next 6 to 9 months an integrated intelligence hub, which is those 2 things. A, it's about having data, but B, it's about how do we come together to look at real community engagement, really move on the neighbourhoods and localities working out some of the complexities and the working with the LCNs. And I think critically for the board, one of the things we want to do is to bring back some outcomes. So this is great. There's a set of there's a set of priorities in here, but the big question is, and so what, and how do we track progress? So one of the proposals would be that we work jointly to create a set of outcomes. Those are outcomes around the big dots that we want to look at to move over the course of the next 5 to 10 years, or even kind of further forward than that, which sort of says if we're successful in all of this, what does that really mean for the outcomes for our population in Somerset? So I think what we're looking for today is agreement of that as an approach, a recognition that a lot of the day-to-day work on this will be the kind of day-to-day work that the integrated care board will be doing anyway. We need to make sure that we create that link, and a bit of a discussion on the priorities. Stop at that point.
Okay, thank you, Jonathan. And just looking around the room for any questions. Lisa.
Only a quick tactical one, but in terms of the 17-year deficit that you talked about there, from long life and healthy long life, in terms of how Somerset compares to elsewhere, what does that look like? And the subsection question would be, and if someone else is so much better, are we borrowing with pride all of their plans?
I mean, I truly might want to comment on this. I think the gap in Somerset is slightly bigger than the national average. I think the national average is about 13, 14 years. I honestly think there's something about us changing the narrative of the conversation, because I think a lot of systems aren't having this conversation, so they may not even recognise that this is a really fundamental issue for them. I think the question about can we learn from other places is a good one. There are some real particular points in Somerset about rurality, coastal communities, and that whole point about the ageing demographic as well, which I guess would mean we might expect that to be slightly higher. But I think you know, there is something about trying to change a little bit the national narrative on this as well. So there's a recognition that fundamentally, actually, for you know, putting my NHS hat on, this is the issue we need to crack in the long term. But Trudy, I don't know.
Yeah, so you're absolutely right. And we have a slightly longer time period than other areas. And that's for two reasons, really. One, because actually we don't live quite as healthier life. And that's absolutely right. But also because we have slightly longer life expectancy than the national average, you kind of push it down one way and push it up the other way. So it gives us a bigger gap. So, but technically, because we've got longer life expectancy, you know, our health services are clearly doing really fantastically well at keeping people alive for longer. Technically, the bottom end of that should move up at the same pace as the top part of it, but it's not in Somerset. And so we live a longer period of time in poorer health than other areas. And don't quote me on this because we're just still looking at this at the moment, and we don't have this data for other areas, but we think that people in Somerset, I think Alice, you might remember, but we think that people start to get what's deemed as a long-term condition or a disability at around 61 for men and 62 for females in Somerset. And it's really useful to look at it that way, to start to see when people do start to get that ill health starting to manifest, because actually then it gives us an opportunity to say, actually, we need to work just ahead of that, as well as working right the way down at cradle. But we need to work just ahead of that to see if we can prevent those long-term conditions from developing and accumulating over time. That information we've only got for Somerset, and we're still looking at that at the moment. So as I say, don't quote me on it just yet. But that information isn't available in other areas. So we don't know when that line comes for other areas. So we can't compare that. Does that make sense?
Thank you, Paul. Just, I think building on that, although it manifests at a certain stage, the seed is sown very, very much earlier. And that's not something which we can cope with through people's dependency upon our intervention. It's something that will be resolved through the integrated neighbourhood teams, the community neighbourhoods and so on. If you like, owning and being aware of the challenges that will lead to it. And when we look at the chart, we can see in areas where it is worst, symptoms and periods of unhealth occurring as young as 12, 13, and so on. And there's something about helping, and this plays again comment about communication and engagement, something about helping people understand the consequences of what appears to be a minor thing at the age of 12, 13, 14, or a phase people go through, all those things, to try and help people live healthy lives from an early age, as opposed to hoping we'll catch them when they reach the point of dependency to a great extent. So to me, what we're talking about here is we need to be able to help local communities influence each other and own that challenge of how do we live a healthier life. And it's daunting when you look at the chart for those who are really suffering, how long they spend in and out of ill health before they get to the stage where they're deemed as living an unhealthy situation. It goes back right to a very young age. So really important that we help people understand the consequences of what they're doing from an early age.
I totally agree. We need to be starting with the circumstances that people are born in. We need to be starting right from word go to make sure that we're giving people the life chances that they need and deserve, as well as the healthy behaviours that start to form at really early age. That also, so that work needs to happen. What we also need to be doing though is recognise that actually there are risk factors that you can turn around in middle age in particular. You know, there is no reason why, you know, if somebody was a smoker now, actually, if they stop smoking, actually you can get the effects of smoking out of your body almost entirely within 10-year period. So actually, we absolutely do need to do the work with younger people, but actually we also need to focus very much on working age adults in particular, who are the people that are going to be coming through with the longer term conditions in the not too distant future.
Thank you, Trudy. Camille.
Following on from that, it's not just about our older population. So if we are looking at the working age, it's about those people with a learning disability, those people with mental ill health, that we absolutely need to make sure they don't become that older adult that then we constantly work with. So if you look at our adult services, it's probably about the age of 85 that we're starting, if we look at the average age that we're supporting, so, and living till well into their hundreds. So that length is the length that you were talking about earlier, but we've got to deal with that early adulthood life as well.
And Jonathan.
I was just going to highlight, I mean, in the paper, there are some examples of some work that we've been doing over the last year or so. One of them is the work around coronary vascular disease, and particularly hypertension. And so, you know, we set that as a priority for our system. It dovetails with that sort of national priority, but it has really highlighted some of the challenges of doing this, because I think there's something about really key to that is having a kind of communication engagement campaign that is really targeted to populations where we know that there's higher incidence. But you can shout really, really loudly, and you can do a lot of that sort of targeted intervention, and the impact, the gearing of the impact is relatively small. So I think there is definitely something about us as a system then really getting behind one or two of those priorities and really going big on it, rather than trying to spread our bets against a whole heap of things. Because as soon as you get outside of the four walls of the building, actually it gets quieter and quieter as you get further away. And there's massive potential in that, with potentially 50,000 people with undiagnosed hypertension, which leads to stroke and coronary vascular disease out there. And actually, although Trudy would like us to get really further down the line in terms of primary prevention, that's the sort of preventative activity that could have an impact this year on hospital admission rates. But actually, we've all got to coalesce behind it, and we've got to be much more intelligent in our targeting of communication engagement and working with population. So some of the work that has been going on in the farmers markets in Somerset is a really good example of getting out to a community that really wouldn't have engaged with these sorts of things before. But we need much more. We need much more of that. It's not just about the approach maybe we've taken in the past, where we put some blood pressure monitors in libraries and hope that people will come. It's got to be much more targeted. And I think it plays to Colin's point about much more targeted education and support for people. But it's further than education. Really. It's about engaging the population in some of these things.
Sorry, Bill, to prolong it, but actually, I think that's a really valid point, and I want to give the board a really, really tangible example from last week of just that. So on the hypertension work, we started some joint work with Langport Surgery last week, just to test our processes about case finding in the community for people who didn't know that they'd got high blood pressure. And so it was a really, really small pilot, but 50% of people that we tested the blood pressure for had an amber kind of reading. So we would be concerned, and we would want to follow them up with more regular blood pressure monitoring ahead of them getting any treatment potentially. But so 50% of people were tested, came out. Actually, all of those 50% had blood pressure monitors at home. So they'd already had their blood pressure taken within the last 12 months. So actually, they weren't really the ones that we wanted to find. They were the ones that potentially are people that will potentially access services anyway, are already keeping a bit of an eye on their blood pressure. Actually, what we wanted to do was really, really find the people that haven't had their blood pressure taken for the last 5 years, don't access services. won't go into a pharmacy necessarily and have their blood pressure checked, won't go into the practice, have the blood pressure checked. So it really, just even last week, that came to light, because it really shows to us that actually to really find the people that need it more than anything, actually we're going to have to work considerably harder. So it's not just about going to any community group. We're going to need to get into those communities much deeper than we even thought at that point. So it was just a really good example, but it's also a really good example that we saw in COVID. So the work that we did alongside NHS colleagues, looking at the vaccine rollout and looking at what we had to do to get right into those communities that really wouldn't necessarily come forward for their vaccine in a normal way, was incredible. We need there's lots of learning that we could use from that to apply to things like cardiovascular disease now.
Thank you. I've got James and then Ad.
Thanks, Chair. So, Jonathan, I think it looks good. I think I kind of support the vision, the model of care, the priorities. We don't mention death or dying, I don't believe, once in here. And it's and it's the same principle, probably low intervention, community supported, use of resource, all of that. If we get that, we talk about, I think the closest we get is life expectancy. And so just making sure we don't lose sight of that, I think, is important. And partly kind of I reference, it's something that's writ large for Somerset with everything. That's why I kind of brought in earlier the chief, as and when the evidence comes up, like the chief medical officer's report, making sure we don't lose sight of that. So, but I think that the principles we apply the same, and absolutely the focus about helping people live well is there, but that opportunity to die well as part of it, using the same principles. Thank you.
Thank you. Adam?
Yeah, I think we need to think out the box a bit more with blood pressure and getting people to come and take their blood pressure. Is there not a way we can look up, like I did last year, Trudy, the pop-up stores in supermarkets? I think that would be a good place to catch people as they come in. Also work with big businesses, because people who are working age find it very hard to get a GP appointment. I rang the doctor on Monday at 2 o'clock. I was 29th in the queue. So I decided after 45 minutes to hang up. There's lots of people who will just not bother going to the GPs because they can't get an appointment. So we need to think outside the box how we get people's blood pressure monitored. I've said many times that I'm more than happy to go into businesses and talk to businesses about getting blood pressure monitors in there. And I'm also happy to do the pop-up shops again, because I thought they worked really well. And just wondered if we could have some uptake on this, because this has been going on for a long time, and I'd like to get something delivered in this area.
Yeah, so it's all on the cards. Absolutely. We needed to do some work beforehand to be able to test the processes, make sure that we've got the response that we need when we do find cases, but it's all in hand. And Bernie and I have been having conversations over the last week or so about the fact that we need to go big with regards to the messaging around blood pressure for the new year. But actually, that will only touch certain people. So we need to do some big campaigns to get people driven, particularly into the pharmacies, which is easy access kind of uptake of blood pressure monitoring. But then we need to do some far more nuanced and clever work, I think, to get to the communities that we might not necessarily get to previously. And we're working very closely with colleagues in the VCFSE sector to do that, to help us with that work. January.
No, I'll be pushing on this one.
Excellent. Thank you. I've got Heather and then Catherine.
Give me a mic, thank you. Thanks so much. Yeah, it's a slightly different topic, but it was just prompted by something that Jonathan said in his presentation, was about data hubs. And I was thinking they're creating a data hub. And I was thinking that one of the enabling priorities is around development of system intelligence function, which I'm all for. And I've sat in many, many rooms where data, the sharing of data, the access to data, turning data into intelligence is always an issue. So I was going to ask both, I guess, Trudy and Jonathan, whether they think the intelligence side, the data side, is that something that we have assurance and confidence about doing, or is it one of our sticky bits that will need unpacking later?
I just wonder whether David wants to comment on it, because David is leading on the work on this. David.
Yeah, so just to give a bit more context to it. So absolutely, I think it is. It's certainly currently a sticky bit. I think there's a number of elements to it that we're working through at the moment. One is the governance around it, the information governance and the data sharing agreements that underpin it. And that's first and foremost having that safety, security, the confidence of the local population that we can bring the data together in a safe way. The second aspect is technical capability. So how do we build on what we've already got here within the council? How do we bring other data sets into that in a safe way, and also then enable public access to it? And the third element to that is then how do we convert that into intelligence by bringing the analysts and those that are using data? Because at the end of the day, we're bringing the data together to improve decision making, whether that's a strategic level or tactical or day to day. And so that's the program of work we've got in place at the moment. But it is certainly, yeah, currently as it stands, it's an area that I would say is a sticky bit, but we've got a plan around that.
Sorry, just add the point about there's that data at a sort of macro level for the system, but actually if we get that right, it's about providing kind of insight so that people in local communities can be kind of curious about what's going on in their area. The other thing I was just going to highlight is people might have seen last week some of the kind of coverage on the sort of brave AI development in Somerset. Now that effectively, you know, that is a bit of a game changer. We've got it kind of working now in I think 6 PCNs in primary care networks in Somerset, with a view to rolling it out across all of them. And it's been there's an uptake now across the southwest. But essentially what that's starting to do is to identify those people who are at risk of hospital admission in the next 12 months. It's used very much at a practice level, so it's not giving us big data in that sense. But the intelligence that David was talking about at kind of a system level, looking at some of those kind of bigger issues of inequality, I think is really important. But actually this sort of technical development at a local level, where actually you're identifying people proactively and then be able to wrap care around them, is really fundamental, really quite an exciting development.
Thank you. I've got Catherine and then Steve.
Thank you. I just wanted to pick up on Trudy's point about the hypertension work, because I think it's a really good example of what Jonathan was talking earlier about, kind of coalescing around a particular issue, because I think, you know, it's taking time, but actually it's starting to work, isn't it, Trudy? And I think we are thinking outside the box. You know, it's not about outputs either. It's not about the number of people who come forward. It's about whether we get the right people coming forward. And there's a focus very much on middle-aged men who wouldn't normally access that. And we're looking at which voluntary sector organisations are they engaging with, or could they engage with? And we're training up people within those organisations to take the blood pressure. So a member of our team is actually a former nurse, and we're kind of looking at starting that. And I think there is a real opportunity, but it is about thinking about things differently. And it's also about not making assumptions about why people aren't coming forward. So the example about vaccinations is really interesting, where there was a real issue around communities in charge aren't coming forward for their vaccinations, and it quite simply was because they couldn't get there. It was as simple as that. And I think a lot of the barriers are practical. A lot of the barriers throughout COVID and that we're seeing now are related to poverty, to access, to inclusion, to inequalities, to transport, all the kind of stuff in the white. And those have to be part of every conversation that we have.
Thank you, and Steve.
Yeah, Catherine, sorry, on this very similar theme, and apologies to all of the healthcare experts in the room. Stephen Paris was on the Today programme this morning. I don't know if you heard him talking about blood pressure, and perhaps people got a bit sluggish during the pandemic, that we're not checking as much for middle-aged people now, particularly men. It's not just Somerset, and there will be counties potentially having similar conversations across the piece. And I'm thinking, I suppose, at a guess, we might say that those communities most affected are likely to be communities living in areas of high deprivation, which takes us all the way back to your initial point, Trudy, about the inequalities were deeper than we thought, and they got deeper during the pandemic. And there's a really, I was in the Improving Lives strategy on page 10, it talks about the approach, and the first theme of the approach is around equity, which effectively gives us permission to distort resource towards those communities that most need it. So if we're going to have a dashboard, Lou, perhaps it's sensible to say, well, there's a prevailing overarching focus on deprived communities. And that's really possibly the best test of any of the strategies that we're talking about, because is this really about blood pressure or is it really about poverty? And if you look at our sector, sorry, Johnny, you may agree, attendance, school attendance is a real issue. Academic performance is a real issue. Safeguarding are real challenges, and who are the most affected? It's the same communities that Jonathan's talking about, that Catherine's talking about. If we were to have one overarching dashboard that said, and what's the experience of people living in deprived communities in our county, what difference are we making as a board? That would be something potentially tangible that we could point to, even if the impact is small and therefore difficult to celebrate, and it's potentially politically controversial to say this isn't about everyone in Somerset, but about specifically targeted, not necessarily overtly, treated as if they can't understand, or how do we reach out to those harder to reach communities to really engage them in some of the themes of the strategy? Sorry, I'll get off my soapbox. There's a theme in what we're all saying.
Yeah, I think it's a soapbox that I've been on too, and I've heard very many other people on it as well. And I think you've absolutely hit the nail on the head as to the strategic impact that we can have as a board. Yeah, that impact might be small, but what if it's big? That could be hugely transformational. We've all seen the social mobility statistics for Somerset and how there are significant pockets of low aspiration in education that leads to low outcomes, which leads to poor health outcomes. Well, that is a system-wide problem. That's why we need a system-wide solution.
I would say, Bill, I don't think I've ever met a parent that doesn't want the best for their child, actually. And the notion of low aspiration sometimes is a cover for maybe we're not making the offer attractive enough in some way. It just feels as if we had an overarching measure, then we'll be able to measure the output as well as have the intentions to reach it.
I think we can compare notes about low aspiration at some point. I'm not seeing anybody else indicating to speak. So a helpful conversation, Jonathan and Trudy, in terms of both strategies.
Yes, thank you.
Yeah.
Going on with my mic. And actually, maybe if we pick it up in the next part of the conversation, because an inequalities dashboard, if that's the way the board wants to go, music to my ears, if that's what the options are, that's absolutely where we could be looking to develop, within the next year easily.
Super. Okay, Heather, just a brief comment, because I do want to move on now.
Super quick. I think it's slightly wider than just like that inequalities dashboard. I think that's perfect what Steve was saying. It's that thing about trying to overlay the many layers of information that we have so we can focus on people. And I think you can debate all day whether what fair means, but if we've got all this intelligence which is pointing us towards cohorts of people or communities of people who need extra support, I'd be behind that all the way.
Okay, thank you. I think we'll wrap up item 5 there, but I think it's possibly linking into item 6 almost smooth.
We couldn't have written this more
Seamlessly.
beautifully if we tried, actually.
So board priorities for 24-20. It says 24-24 in my notes. I've just spotted. I'm assuming it's 24-25. And I'll hand over to Lou.
Thank you. Max, this is on the bottom of my first slide. So it brings together actually the whole of the discussion that we've had to date. So we ran a couple of workshops prior to the board, which thank you to everyone who could come. Some people did the first one and not the second one, and vice versa. But we agreed 5 priority areas for the board following all of that discussion. So we did an approach taking that 30-year view, and we used the SAWS approach. So what strengths did we have? The opportunities, the aspirations and results. So what does could look like at the end. And we came up with 5. So housing and the importance of housing being one, and we have colleagues with us who are here to present on the next topic, demonstrating the work to date on that one. We had care, particularly social care, all age. Educational attainment, Steve and John, you'll be pleased to hear, was one of the ones that featured also. That prevention and population health approach. I mean, we've talked about communications and engagement. I'd also add into the equation, what we're looking for is behaviour change. We're looking for the behaviour of our population to change and to change in longer term. So it's not just about that communications and engagement. There is a skill to behaviour change, and it's how we adopt that approach as we go forward as well. And climate was the other one. And picking up your point as well, Ewan, we've had looking at 2 priority enablers, one being that system intelligence function. So how do we share the data, share the intelligence, and drive forward the strategic priorities through that shared system development, system intelligence function? And the second one is, can this board lead on that neighbourhood and locality approach? We are well placed to think about that locality and neighbourhood working with the LCNs, the local community networks, the primary community networks, and the locality working that we are all in charge of delivering and developing across the county. Now, we can't do all of those at the same time. So the proposal is to continue with the housing one. So this was one that the Committee in Common prior to the Somerset Board agreed in September of 2022, and quite a lot of work has happened to date, and colleagues behind me are here to talk us through that. But it demonstrates an approach where we started with a topic that is also, I'm echoing somewhere, that is absolutely enormous. And how do you filter down into tangible pieces of work that can be taken forward and developed at a system level? And picking up the metrics idea, I think we'll have a number of metrics, Steve. I think we'll have overarching metrics, which picks up your point, Heather, about how do you overlay the picture of what it looks and what it's like to live and work in Somerset. So those will be the ones sitting under the strategies. But I think as we develop these work programs, we will have more detailed and very specific outcomes and metrics that will form part of the scorecard for the board. So my ask is, are you happy with the proposal that we stay focusing on the housing one for the next year, and also focus on those 2 enabling approaches to the work of the board, and then we can start to look at the other priority areas as the board develops and goes forward.
Thank you, Lou, and looking for anyone who wishes to comment, contribute, or cheerlead. I'm not seeing anyone, in which case you, oh, well done, Bernie. I was about to say she's hit the nail on the head, and then I've got Bernie and then Colin.
No, thank you. It looks really clear and it's concise, which is really helpful. But I was wondering whether, and I suppose this will be how it plays out in reality, so maybe we don't need to be too conscious of this, but it doesn't necessarily have to be so much in series as much in parallel. So if you want to try to work out how a neighbourhood and locality approach works, why wouldn't you road test that through a lens that is around something about prevention and population health, for example? Otherwise, because doing it of itself is somewhat abstract and doesn't necessarily get you anywhere. So that's my only comment is, as we pay attention to the enablers, can we apply lenses that help us move along some way?
Yeah, I agree completely. But I think there is a point where that strategic oversight of neighbourhood and locality needs to sit. So if there's any sticky bits, and we've already heard a sticky bit, where does it come? And I think it's that kind of approach that sits here with that approach, because a lot of work is already happening on data intelligence, locality working. It's not that we're starting from scratch. It's just this Somerset board would be a home for having that strategic oversight. And if we're getting particular, I mean, for example, we know we've got Somerset Foundation Trust work on 4 localities. our public health nursing works on 7 localities. We've got 12 PCNs and 18 LCNs. Where's that strategic conversation? Mel's got 12. Where's that strategic conversation happening if it needs to happen at a system leaders level? It's more that approach, because it will develop as the work goes forward, particularly if we're all, my opening comment, it's for board members, it's about understanding the priorities and taking them out with you into your organisations and the work that you do in your organisation and any associated boards.
Thank you, Lou. And Colin.
Raising a different type of priority for the board, is communications going to be a priority for us, in the sense that, as we pointed out, we're a new board, we're actually taking a radically different approach to things, trying to prevent ill health, frankly, rather than coping with it afterwards. Should we be starting now getting messages out that we're on the case, we're looking to find ways to help individuals to help themselves, and these are some of the topics we're following? I know that will give risks for us, because people will then reasonably say, well, how are you in a year's time, what have you achieved? But communicating that we're on the case along those lines, or have we done it already?
In the past, we always did an update post the board of the work that happened, the work that's been driving forward. We do have one of the colleagues in the public health team, Lisa Rogers, who is our engagement lead. We do need to think about that wider communication and engagement and bringing wider stakeholders and the public into the work as well. So yes, it's definitely going to be something that we will need to strive to take forward as well.
Just so a couple of points. So one on the comms bit. So there's an element of the comms that sits in the system intelligence function probably belies a little bit what it is. So it's two things. It's about data, but it's also about that coming together of the engagement function as well. Actually, just it's a bit of a plug. So I mean, it's a relatively small thing, but one of the things that we're launching this week is our Somerset sort of newsletter. So it's something that's going to start to come out across the system more broadly. That gives some case studies on the work that we're doing, some of the work that we're doing specifically within that wider integrated care system. Now it's only kind of one thing, and you know how far newsletters go, but I think we do need to think more intelligently about how we get some of this information out. But I think the point is that the system intelligence function is about more than data. It is also about our approach to engaging with the population, with people in communities. I was just going to talk, just mention a bit about neighbourhood and locality approaches, because I think there's two bits to this, and I might be thinking a bit binary, but I think in essence there's two bits, and we got into a bit of this conversation earlier in the week. There is the whole piece about how we build resilient communities. So this is kind of unpacking my brain for a minute, but there's a whole bit about building resilient communities, and then there's another bit about just how do we organise ourselves. So how do we organise from an NHS perspective? How do we organise the way that we deliver care in communities? We're looking at the footprint of primary care networks, and I use that language quite carefully because it's not about primary care networks, it's about the geography and the footprint covered by. But how do we organise ourselves? And I think some of that we just need to get on and do, the kind of organisation piece. The real benefit in where we come together is to make sense of how those bits of the puzzle then fit together, so we're not organising ourselves in a way that doesn't integrate and doesn't join up. But it is that broader piece about building resilient communities and how we can make sure that we've got an equal balance on the resilient communities development, as well as the how do we organise the sort of nuts and bolts of services and support that's out there already. So I don't know whether that's a helpful way of thinking about what we're trying to achieve.
Thank you, Heather.
Thank you. Again, it's some interesting vexed kind of questions here, but they're really good. A couple of things I was thinking of was the point about shouldn't we be looking at prevention, because it's such an important thing, and it's why do one thing at a time and try to do things together. I was thinking all of the organisations in the room will be working on prevention and early intervention in their various ways. And I guess the trick might be that we all have to be thinking, instead of just, as Jonathan said, instead of saying, what are we as the NHS doing? And you'd think that, or what we were doing as Somerset Council, but then having that extra bit, which is, and how does that apply across the system? And are we making the most of that system connection when we're doing our day-to-day job? And it's our job to be challenging our our colleagues to think that way, I think, every day. I think that's quite an important thing to be thinking about. And I think the other one around the neighbourhood bit, I'm really pleased you separated out the idea about resilient communities and then how we organise ourselves, because they are kind of two separate things. And that's really important. And the last one is on Colin was communicating. I think absolutely right. And the idea and how we, because again, I've always thought, well, public health sends all such fabulous things out, when that happens, or Safer Somerset Partnerships send some stuff out, or we send stuff out. And again, I think if we can have that more, if the system is sending stuff out. But again, I don't think the people out there want to know that there's a system. They don't give a monkeys about what NHS, some Somerset NHS is, because they won't know the difference between that and the NHS or Somerset, but it's all that outcomes bit, but in a much more kind of holistic way, that we've got those great stories that are showing how the system's working. Just a thought.
Okay, I'm not seeing anybody else indicating, but now I am. Ewan.
I actually do think that's a really helpful framework, actually. So resilient communities, the composition of this board, I'd say, is exactly right, because you've got to, it's not just the health services, it's working with all of the bodies out there. I would say some of the 5 priorities probably lend themselves more to neighbourhood approaches than others. I mean, yeah, prevention's already been picked out, absolutely, but obviously housing very neighbourhood focused. Climate can be in some of its aspects. I think the question of how the health services organise themselves is quite a key one, and maybe that is a benefit of the unitarisation that we've not tapped yet, because we have very different approaches in former Mendip and former South Somerset. There is the Health Connections Mendip model, which I personally consider to be the gold standard in the way to operate. We've got in former South Somerset the primary care rural practice network, theoretically, but it's never been fully staffed. So we have a team of health coaches who do great things, but the infrastructure behind them isn't as strong as just up the hill and across the border. So that might be something to look at. It's like, can we find a one Somerset way of doing neighbourhoods and locality?
That's spot on. I think we've got some really good areas of practice in Somerset, and but not every area has adopted the same thing. And there's the balance for us is about trying to find the things that we need to do across the whole of the system to make sure that there is consistency and be able to resource those, and also to enable kind of local ground up, bottom up innovation to happen as well. But I think there is definitely work that we're doing at the moment around kind of evaluating those various models and saying, actually, do we need to now provide some consistency across Somerset? We've been really good at doing some pilots, letting some things develop, but actually we know that now that there are some things that really are working. So absolutely agree.
Okay, and lastly, Paul.
Just quickly, I think it's, if I go right back to the very beginning when Lou was introducing us, and what an extraordinary group in some ways we are. The key thing is that we all take back to all our different enterprises that this is a common cause across the whole of the system, and therefore we encourage all of our team members to communicate in an aligned way, and not to point at each other, but rather to go, this is what our purpose is here. And that's that sense of communication, which is whether it's a consultant in the hospital or a social care worker visiting, or a district nurse on the thing, or a environmental officer, somebody they all know that this is our purpose, and that communication and data intelligence will be really helpful. But it's our task partly to hold to account all the people in our enterprises who try to separate from it, and just to keep it. That takes repetition, constant holding to account for it. So it's a really valuable thing to be able to do, but it isn't always easy because people find it difficult. Thanks.
Thank you. So we do have recommendations in front of us on this item, that the overarching topic priorities, the Somerset board be approved, and the priorities of the board to be focused on for the next year, 24-25, namely housing, and the two enabling priorities. I'm not sure whether we're under a standing orders, whether we take formal votes, but am I seeing general assent for those across the board? And everyone seems to be nodding, so we will take that as confirmation that those recommendations are approved. This one, I'm just so that we're aware, I think we're going to be finishing about 12, which is 20 minutes behind schedule. So do apologise if anyone was hoping to finish on time. We'll be slightly behind on my current chairing, so my apologies. We have an update on our housing item, and I'd like to invite Alice Munro, please, to present. Thank you, Alice.
Hi, I'm Alice Munro, consultant in public health. I'll be presenting on an update on housing and health and work to progress the MOU that was agreed in 2020. Excuse my voice today. But the presentation is going to just include a very high level overview of some housing and health, of housing issues that impact on health and care issues that impact on housing in Somerset, as well as some of the existing and ongoing responses and some of the current and future opportunities to address them further. I'm going to start with just a, brief background. So there was an MOU agreed by the Health and Wellbeing Board back in 2020, which agreed a few priority themes around housing and health. And in more recently, those were narrowed down to these three themes, one being homelessness and rough sleeping. One is independent living, particularly talking about adults with disability and older adults, and one being health impact assessments. So we'll give an update on each of these in the presentation. And Mark Lehman here is Housing Strategy Lead. He'll also be presenting some of the slides. And before we go into that, I thought it would be helpful to be all on the same page as to the relationship between health and housing, and a variety of ways in which housing impacts health and which health can impact people's ability to maintain a suitable and decent home. So housing is, I'm sure we're all aware that a stable and good quality home that meets our needs is a core foundation to be able to lead a healthy life and actively participate in our communities and hold down a job and all those things which are enabled by having a stable, suitable home. So suitability of homes is one of the pathways by which homes impact health, and that can cover suitability for an ageing population. So is it adapted? Are we building enough lifetime homes? Is it suitably adapted for people with mobility issues, as well as people with other needs? And in many cases, those are escalating needs, but in many cases, we're talking about people who need step-down care or are de-escalating needs, but who can't transition straight from a very supported living environment to independent living in an unsupported home. So there's a variety of issues around suitability of the housing provision in Somerset. Affordability of homes is an increasing issue as housing costs rise, both for rental and ownership purposes, and that disproportionately affects households with young children. So we've got rising numbers of children growing up in after housing cost poverty, and of course childhood poverty is a core determinant of health, as well as social mobility and educational attainment. Then quality of homes. So this is touching on things like the decent home standards and the housing health and safety rating system. And we know that we don't have a very clear picture of how many homes in Somerset don't meet the decent home standard. So issues like damp and mould, fuel poverty, overcrowding, but those are things that we don't have a comprehensive data set on, but we do know that they impact people living in the private rental sector and many owner occupiers more than those in homes owned or delivered through social landlords. And then finally, housing security, of course, is critical to avoid people being faced with homelessness. So stable housing links closely with affordability of housing, but unstable housing has a huge impact on people's ability to engage with services, stay in touch with healthcare, for children to stay in education. Children are in temporary accommodation, they can often drop out of education and have and also not be reached by health visitors and other services. So security of homes is a critical pathway. And then finally, as a foundation for all that, it's about the neighbourhood and the built environment and the natural environment around people that enable people to engage with their community and participate and live active, healthy lives and access services. So it's a very summary overview of housing and health, but these were some principles that have been agreed previously to inform our housing work. I'm not going to read them all out, but to summarize some of the key ones, it was broadly agreed that we need to be working in a really personalised, holistic way with people, recognising that housing often is just one issue people are facing among many. And to enable that, we need to be working in a really integrated way, multidisciplinary way, and that's a recurring theme of this presentation. And we need to be working in a preventive way to avoid health and care needs escalating due to poor housing and to avoid people's housing issues escalating as a result of their health or care needs. I'll hand over to Mark now.
Yes, hi. Mark Lehman, Housing Strategy Lead Officer in the Housing Director at Somerset Council. So, bit of context, national housing crisis. You hear about this daily almost, don't we, in the news, which is playing out across Somerset. We have particular pressures, cost of living crisis, more rough sleepers, new to the streets, some figures there. Q2, we had 86 new rough sleepers on the streets of Somerset. We have about an average about 80 to 100 at any one time. People sleep on the street, sleeping rough on the streets of Somerset. More people in temporary accommodation, bed and breakfast figures there, rising. End of September, 255 people in bed and breakfast. And worryingly, an increasing number of children and families. Other pressures, health and care needs, rising complexity, so need for bespoke solutions, both around accommodation and supports, social housing, shrinking resource. Right to buy continues to pinch on our stock. Hinkley Point C, rising workforce. Figures there, projected 2025, 12,500 workers on site, of which the majority are not Somerset based. They are accessing mainly private rented sector or campus facilities, but that is of course impacting on availability of accommodation. Of course, there's other major employers coming into Somerset too, which is good news, but it does place pressure on the housing system. Displaced persons, we've accommodated 2,500 already, more coming in, Afghans, Syrians, etc. Extra pressure on the housing market. Private rented sector, really expensive in Somerset, caused largely by Hinkley pressures, and we're at capacity, particularly in the west of the county. Former Sedgemoor, Taunton Dean, at capacity. It's a shrinking resource, more landlords leaving the market. Key worker accommodation, that's a big challenge for the system, particularly across health and social care sectors. Just on that, I mean, I will say, I don't want to dwell on this, but there is plans within the ICS to set up a housing hub, which is a initiative funded through health and care and supported by housing to assist migrant workers into the county, a sort of one-stop shop, looking to access how we can support accessing accommodation. So that's in train. What's not on there, of course, is the phosphates issue, which is, has been a big issue across Somerset last 2 or 3 years, restricting our ability to build. So lots of pressures across the housing sector. John? Just want to focus on 3 or 4 slides around homelessness and rough sleeping. We do have I won't read all that on the slide there, but just to emphasise, we do have a programme called Better Futures, MEAN, Making Every Adult Matter, which looks at the sharp end of homelessness and rough sleeping. The focus is we have about 500 people across the county that are in supported housing of one type or another. This programme focuses on those 500, in addition to the approximately 100 or so rough sleepers on the streets. So it's a cohort of people of about 500 to 600 this programme focuses on, trying to devise solutions for these people who often have severe multiple disadvantage. Next slide. And this is the challenge that we're presented with. Common mess. So people facing multiple disadvantage, whether that be, mental health problems, drugs and alcohol problems, care problems, criminal justice. They want a solution or help within the spectrum of issues they are seeing and presented with. Whereas we're services pretty much siloed, and trying to support those individuals is often very difficult as we trip over one another and people bounce around the system. So the Better Futures programme meme is trying to find some solutions to how we crack that and actually improve the system to support these people who are desperate in need of care and help, as well as costing us a lot of money. Next slide. So the programme, again, I won't read all that, just to emphasise, the programme to support these people contains 6 work streams. One's around early help and prevention, what supports we put in place to as a system to actually help stop people tripping over into severe multiple disadvantage. Commissioning, how can we actually more effectively commission homes and support for these people? Appropriate use of short-term accommodation. So how do we actually assess and refer these people? How do we assess them and what accommodations are there out there? Access to permanent homes. So once they're going to supported housing, we need to move them on to more permanent accommodation, because supported housing is a limited resource. It's a shrinking resource. It's a resource that's in high demand. How do we actually move these people on so we can get more people into supported housing? That's an incredibly challenging area of work because of the context I described previously. Sustainable tenancies. Once we've got people into more permanent accommodation, how do we actually provide some support for them once they're in their more permanent accommodation? Because inevitably people with severe multiple disadvantage will have wobbles. And we, so what support is there to actually, pick up a phone, who's at the end of the line, to actually help them with their crisis at that particular time? And then the final work stream is leadership and learning, and that includes me coming along to partnerships like this to explain what's going on and seek senior leadership support. I shall move on. So just a couple more slides on this. So what successes have we had to date in this area? We set up a creative solutions group for the East and Western County. These groups look at, there's about 10 individuals across the county in creative solutions. These are the 10 individuals with the most multiple disadvantage, where support and accommodation options are really, really difficult to find. Really hard to actually provide support. So these panels, multi-agency, try to get creative in terms of how we actually accommodate and support these individuals. That's run by a Second Step chair that meeting, one of our commission providers, with adults providing the deputy chair of that meeting. So there's housing providers and drugs and alcohol, etc., supporting that programme. Homeless healthcare team, I won't talk about these, but I'll mention a few. Homeless healthcare team, excellent example of commissioning in this space, which is where the NHS have funded nurses and more money coming in, mental health support workers, to get out there to settings like rough sleeper settings, hostels, to actually provide support where these people are accommodated. And that's had some real success in terms of reduced A&E attendance from this cohort, reduced GP referrals. So that's a really good example of how we sort of, as a system, trying to get creative in this space. The 16 plus contract, youth housing, that's a good example of joint commissioning, I would say, with housing and children's services coming together to find solutions to a cohort of people, leaving care leavers and others, how we actually provide accommodation support to that group there. And I'll just pick out one more, assessment of need. So I mentioned the 500 in supported housing, plus the rough sleepers. We've done a really good piece of work with the housing providers, voluntary sector largely, to understand the range of needs of that group of people. So we know we've got a good sense of mental health conditions, severity of drugs, alcohol, severity of problems, physical health needs, criminal justice, what's going on. We've got a really good sense of what's going on. We need to refresh the data, but the logical next step is to, as a system, housing, health, care, others, to understand what that means in terms of our service delivery. What's it costing us? How do we stop these people bouncing around our systems and get creative around that? That work, important, is slowing down, and that's because of the situation we find ourselves in at the moment, the financial crisis. It demands capacity, and I'll be honest, we're struggling actually with this at the moment. It's not going very far. Next slide, final slide on this section. So just to say, in progress, yes, the commissioning plan's in progress. We were hoping to have something in place for 24, 25. That's not going to happen. Is 25, 26 an option? We hope so. Creative solutions, again, this is the 10. What can we learn from these 10 people? They are absolutely bouncing all over the place. They're costing us a lot of money. We need to understand that to some level of detail to enable us to devise solutions and for the system. You notice that I don't describe these individuals as complex. These are individuals with severe multiple disadvantage. It's the system that's complex. Homeless and rough sleeper strategy, that's started. That's a huge piece of work, statutory responsibility of the council. The review's commenced. We need to have that finished adopted by March 2025. That's a DLUT requirement. That gives us opportunities to have further conversations around this space. The final thing I'll just pick up on, the governance around this is the Homeless Reduction Board. I forgot to mention that. So we do have a governance structure around this work, and that's the Homeless Reduction Board. One of the things the HRB wants to see is a system of homeless mortality review for Somerset. These are people, unfortunately, we have a fairly high number of deaths on our streets, in our supported housing settings. A lot of these people did not qualify for SARS. They're below SARS threshold. But as a system, we need to understand what's happened to these people. So they're learning from their deaths, and also to give people a sense of, the people working with them, the providers and others, a sense of acknowledging that life, providing some sort of emotional support. But these are traumatic events for a lot of housing providers when people die in their settings. So that's something which the HRB wants to see, and I'll be hoping to engage our SLT around this in the new year. But I'll pass back to Alice.
So before I move on to the other MOU topic areas, just to add in one case study from the homeless health needs assessment, because we can't cover the whole needs assessment here, but this is just an illustration of the ways in which the homeless health nursing service, by approaching communities to support them with their physical health needs, are actually also taking on a much wider role. And this is a case study of a young woman who was pregnant and sleeping rough on a roundabout. She was an opioid substance she was an opioid user, also a sex worker, but she herself had been groomed as a teenager. and so severely disadvantaged, obviously, and extremely traumatized, facing multiple issues, not just physical health issues by any stretch. And so that GP for the Home Health Nursing Service acted as the care coordinator for that young woman, and they not only helped them with their opioid therapy, but they also helped them into temporary accommodation, to access all the benefits that they were entitled to, as well as bank account, and then to move her into a mother and baby unit further along the line. So it's a very holistic approach taken by the team that goes well beyond just physical healthcare needs. And some of the recommendations, there were 13 recommendations made in a homeless health need assessment that was recently conducted. So I won't cover all of them here, but a few that are worth noting are one around the need to develop an overarching homeless people's health strategy that links in with the NHS Core 20+5 priority group of homeless adults to help deliver on that priority. Another is to develop a collaboration to provide accommodation and support for people affected by homelessness that includes outreach, residential provision, and a hospital pathway as well, so that there's a continuity of care for people and support. And then care coordination, continuity of care links in with that. And then finally, local pathways for substance misuse treatment. And so that, you know, from detox through to rehabilitation and getting people back to independent living, so that they don't at some point drop out of the system, drop out of the support, and then end up relapsing. So these are some of the high level recommendations that are just worth bringing to the attention of you today. Now, when talking about homelessness and also independent living, the conversations tended to sort of always turn to young adults as well, even though young adults might not necessarily ones that are homeless or severely disabled. We decided to just do a bit of an analysis to look at some of the housing issues affecting young adults, and began by just getting an analysis done of Home Finder Somerset data, as well as looking at some of the census results this year or last year. And from the census, one of the interesting findings is that one of the reasons young adults are so affected by the housing shortage is that the number of households in Somerset is rising a lot faster than the population, meaning we have a lot more one-person households, which is often where somebody's been widowed or separated, but the housing supply is not meeting the needs of the population because more people are just living on their own, occupying houses that are bigger than their needs. We have far more under-occupied homes by a long margin than overcrowded homes. And so this obviously puts pressure on the housing stock, and that disproportionately affects young adults more so than older, middle-aged and older people who probably already own their own homes. Makes it very hard for them to both get into the private rental sector and onto the property ladder. And so this is then reflected in Home Finder Somerset data, where this is the portal for applying for social housing in Somerset, and 46% of applications to Home Finder come from under 35s. And we know that those who are categorised as silver or bronze are unlikely to be offered accommodation because the supply just isn't there to meet people with low priority housing need, or what's classed as that. And what this translates to is that they are in the 16 to 35 year age group 3 times more likely to be applying to Home Finder than adults over 35, and that has a dual impact both on them, and their vulnerability to poor housing, to insecure housing, to unaffordable housing. It's a direct impact on their health, but an indirect impact on both the children they might be responsible for, and also parents and older adults they might be trying to care for and support in their staying local to home. So some of these factors cited by young adults are quite different to those cited by older adults, and it's a particular concern around mental health and well-being because it was in the thousands the number of people citing mental health and well-being made worse by their living, by their property, or by the surrounding environment as a factor in why they're applying to Home Finder, as well as many facing homelessness And many also saying they want to be near to family in order to give or receive care. So of course that has impacts on our systems when people aren't able to live nearer to family. And so then this leads into older adults and their housing needs. Just so I'll try and speed up here because we need to get to the conversation. But the census also showed that we've got an aging, well, we know we have an aging population, but just dramatic increase in adults over 65. And we also know that their care needs are going up. So it's projected that by 2040, we will have 60% more over 65s who are who have one or more mobility issues than in 2020. So dramatic increase in people facing mobility issues, both because of the aging population and because of poorer health among those in that age group. This was the just as a brief summary of the points agreed in the MOU back in 2020. So those include delaying admission and delaying transfers of care of people from preventing delayed admission and preventing delayed transfers of care, but also maintaining people's ability to live independently and reduce chances of a life-changing health event. And so these are all our the system priorities for supporting people to live independently and reduce demands on the system. And interestingly, this has all been reinforced just very recently by the CMO report that's come out on healthy aging, or health in an aging society, where he makes the same, the final 2 points are restated in his recommendations, that we need to be building communities that are suitable for people who are aging, as well as reducing chances of a life-changing health event. So there's a few strategic programs to support independent living at the moment. This doesn't cover all of them. One is around personalised care that brings back that theme of the need to work in a multidisciplinary way. And that's particularly important around independent living, that personalised care is about recognising that people's lives are complex and the system is complex, but that people are not, people need support to navigate the system in order to address all their needs, rather than just having to be siloed down one pathway that only addresses one of their needs. And the complex care teams are an operationalisation of personalised care. In South Somerset, there's a pilot of a complex care team which has recruited a social worker who's able to engage multidisciplinary services, wraparound support to individuals, and they've dramatically reduced wait times for adult social care assessments. It's gone down in that area from 200 to 27 days as a wait time, and the list of the number of people waiting in that PCN has reduced from 80 to 12. So there's huge potential for progress, but what we don't have yet is any system-wide infrastructure to support personalised care. And then beyond that, we also have Somerset Independence Plus. Many of you will know about. They administer the Better Care Fund and support people accessing things like disability facilities grants. They also contract Safe and Warm Somerset Helpline, which supports people affected by fuel poverty and cold homes. So these deal with many housing adaptation and housing quality issues to help people stay independent in their homes. And then adult social care also have independent living centres. So I think there's 2 now up and running, so that people can go and test out equipment that they might want to install in their homes. But to bring it back to the ongoing and future challenges, one of the points made in the CMO report, and which is worth considering, is that to really do this efficiently and effectively, we need to, rather than adapt one home at a time, be thinking about how we build our houses and how we build our communities, so that they are, at a system, at a place level, adapted for a population with much greater mobility needs, much higher rates of disability than currently. So we don't want to be relying on retrofit measures. We need to be building it in, which is where the local plan comes in. So I'll just quickly touch on health and planning, because health impact assessment was the final point in the MOU. So the planning system can support us with that through things like building to lifetime home standards, building appropriate homes for our population needs. So for example, you might want to have many more 1-bedroom or 2-bedroom homes in some areas, rather than detached family homes on the edge of towns. They can also support with the built environment around homes so that we've got streets and parks that are accessible to people with a range of mobility needs. And they can limit the drivers of unhealthy behaviours. So, for example, limiting licensing of certain types of like fast food outlets or other types of licensed properties. So health impact assessment, we've had some workshops now with the Office of Health Improvement and Disparities. The upshot of those workshops is very much that health impact assessment of planning applications is a really valuable tool to help us inform what we design and build in the future. On its own, it's not enough. You do need to have health in all policies and health written through the local plan and any supplementary plans that accompany the local plan. In particular, if we do things like design coding, I won't go into that here, but design coding would have a much wider impact than just health impact assessment, and would mean that if you've got a health impact assessment that comes in as submitted by a developer, that you can then go back to that developer and comment on their plan and with reference to your design codes. And your design codes give you some sort of leverage and enforcement power that you might not otherwise have. And other policies are also important there. So essentially, there is great potential through the local plan to be building homes and places that are fit for the future, but a huge amount of work for health and planning. And in many areas, the starting point for approaching this has been to develop a framework agreement between health and planning. And that's something that could be considered as a sort of directive from the board, is to develop a framework for the ICB, public health and planning, to really consider what priorities we want to try and distill through the local plan. So just finally, I'll hand back to Mark.
Yeah, just very briefly, just mention some of the challenges. Some has been mentioned. Our finances, of course, are a pressing problem at the moment. It's, you know, a range of services are required to work in this space, and we're experiencing very significant challenges. Officer capacity is being pulled in various directions. Uncertainty around resources, that makes it quite difficult when strategizing on developing action plans. You know, you need some handle on your resources, and that's quite difficult at the moment. Yeah, and the external environment is, as mentioned, is also challenging. Yeah, next slide, guys. Just to say that, I mean, there are opportunities, more opportunities for conversations and joint working. Mentioned the homeless and rough sleeper strategy. That work is ongoing. Lots of conversations next year around this, working with partnerships and providers and others in terms of looking at gaps, looking at demand, and hopefully finding solutions to some of that. That work will be supported by the Better Future Than Mean programme for the sharp end of around homelessness and sleeping. The government have announced that councils will be, it will be a statutory requirement of councils to prepare a supported and specialist housing strategy. That's coming in 2025. So that's looking at, that will cover some of the matters covered by the homeless and rough sleeper strategy, but it covers other types of accommodation too, such as learning disability, autism, mental health, etc. So that's something as a council we need to understand and start working on. And of course, there's the local plan review, and I think, as Alice has stated, is absolutely a critical need for planners to be brought more into the conversation here in terms of identifying solutions on the accommodation side for the problems and challenges that we're experiencing. And that's it, I think.
Thought out. It's a test match special gag that they give the commentator a slice of cake just as they hand over. Sorry, excuse me, there was a mouthful of mince pie. So thank you so much for that report and all the work that we're doing in this area, both Alice and Mark. I really do appreciate everything that goes on, and those cases that are complex in our systems to respond to are particularly difficult and tricky. But I was very impressed with that last point about the need for our new local plan to be able to identify a lot of those opportunities for people to live more healthily in their own communities. There's lots of learning from new development in my community as to how that could have been done better had it been thought about more at the planning stage. So yeah, some really good thinking there. So I've got Liz and John, and then Angela, and then Ros online. So we've got a whole series, but we'll have Liz first.
Thank you, Chair. Ros may be about to say the same thing as me and Heather and possibly John. I just really ask that we can feed in the work that's been going on in and around Glastonbury with regard to van dwelling and caravans. We're looking at the possibility of 3 planning applications coming forward in the next weeks and months, working with, believe it or not, Homes England, as well as Julian House. So I really want to make sure that we don't lose the learning from that work of the multi-agency group over the last few years now. Thank you.
Thank you. I was going to say something very similar, but it was also the quantums of homeless people. That you said 500 to 600. If you look at sort of those that haven't got any accommodation, is that understated? How do you get that value? Because it feels like a lot more when we look at what's happening in Glastonbury.
The 500 is just those in supported accommodation. So you sort of your Lindley House and other types of accommodation across the county. There's the level of homeless. If you look at Home Finder, there's 11,000 plus people on Home Finder looking for property, and we can accommodate about 2,000 a year by working with the social housing, affordable housing sector. So there's a huge lag in terms of demand, need. So the 500, yeah, that's just those that are, you know, at the sharp end. Also, maybe rough sleepers, we found accommodation for them, but the actual scale of homelessness is way beyond that, way beyond that.
I wanted to add as well concern around affordability issues driving increased risk of homelessness. You may have heard there is talk of the work capability assessment being reviewed. Will that assessment will affect people living with health conditions, and many people use the additional benefit or financial support they receive to top up their housing payments. And we might want to ask DWP to feed some data into through JSNA around the number of claimants likely to be affected by review of the work capability assessment, because that can then indicate perhaps increased risk of households not being able to afford their housing. Thank you.
And Ros online.
Thank you. Forgive me not being with you, but as you can hear, I got a rather antisocial cold. The key thing about housing, and I'll say this with 2 things. First of all, our experience in Mendip, the numbers are absolutely understated, and we know that because people are sofa surfing and all the other things, to say nothing of the elements of us sleeping in tents. They're not just on the pavements. The other thing I was going to say, as the executive member responsible for the local plan being brought forward by 2028, I can assure you that this element of input regarding health and housing is critical. I think the planning team recognise that, but I think the point made about getting the right resources and the right people in the room during the development is going to be critical. But it is very much on the agenda, just for some reassurance to the board.
Thank you, Ros. I'm just looking around for any other contributions before summing up. There wasn't a recommendation that on the paper for this, but just wanted to put on record our thanks for all the work that's been going on around this area. We do recognise that very close relationship between housing and health, and particularly those that are in homelessness or in substandard quality of housing as well. And there's a huge amount of work to be done around this area, which will be preventative in nature in the future. So thank you so much for all your work that's gone into this. Okay. Moving on to item 8 on the agenda. Louis got questions on circulated reports, and that includes the pharmacy consultation in Glastonbury. Am I seeing any questions that arise from anything circulated? No. Thank you very much. And any other business? I've been notified of one item of any other business. Is there anything else? No. Adam, did you want to raise it? It arises from our adults health.
Yeah, I think it's quite quick to sort of bring up and resolve here because it's mainly for the ICB, but I'll just read some words. I've been asked by the acting chair of Somerset Adults and Health Scrutiny Committee to make their views of the consultation of stroke services in Somerset known to the Somerset Board. The committee would like to request that the ICB decision scheduled for January 24 is delayed to consider other options for stroke services in Somerset. I'm sure the ICB will respond accordingly, and I ask this board to note this request and ask the ICB to look at this and get back to our adult scrutiny board, please, if I may.
Thank you. I think the request is duly noted. It's been a long-running issue as to where stroke services are located and where the expertise is to respond to those. I know from personal experience with my late wife having had a stroke, the need not only to get the support in place quickly, but also to have the right expertise in place to be able to respond as well. In her case, that need was up at French Hospital in Bristol. It wasn't available in Somerset at all, and I was grateful to have that expertise that saved her life when that happened. But we do recognise that there is considerable public interest in this decision, and we know that this is a very difficult one for our colleagues to resolve. Jonathan, did you want to respond?
You want me to comment? I mean, it's a big topic and it's probably bigger than we've got time for here today. But I'm just going to say, I mean, we clearly received a letter from yourself, Bill, following the HOST meeting last week. So we will respond to that formally. As we sit here today, the decision point is the end of January, and we're working towards a decision-making business case at that point in time. So we recognise the decision, but that's the timeline that we're currently on. But we will respond formally to the letter.
Indeed, and we felt that this was the correct forum just to advise of that feedback from the scrutiny committee and the elected members there. Okay, I'm not seeing any indications of any other business. So thank you so much for your attendance and engagement in the very interesting and strategic issues that we've discussed here. And we look forward to hearing progress at our next board meeting and through our workshops and other events. Thank you so much, everybody. Thank you.